Arthroscopy actually is now involved in the treatment of erbs palsy, mainly in all children, young adults, and even adults, as I'm going to show you. Well, the etiology and pathology is well described by my colleagues, so I will skip that. Just I want to mention that most infants with brachial plexus palsy will recover with daily physical therapy exercises. Now, the problem is that external rotation weakness secondary to obstetrical brachial plexus palsy lead to internal rotation contracture of the shoulder, causing functional and cosmetic problems. The persistent muscle imbalance and soft tissue contracture can lead to progressive glenohumeral deformities. Now, the treatment, as mentioned before, is non-surgical treatment, daily physical therapy, and the surgical treatment when there is no change over the first 3 to 6 months, as nerve graft, nerve transfer, or release and tendon transfer. The target of the physical therapy is to break the advancement of the disease by keeping normal passive motion to avoid contracture, stretching and strengthening of elevation and external rotation, and continue that for at least 6 months to 1 year. The arthroscopic options of treatment are arthroscopic anterior capsular and subscapularis release, arthroscopic subscapularis release with open latissimus dorsi transfer, or the 2+3 repair technique for limited goals, which is a technique we use, which I'm going to explain later, mainly for adults. Now, the arthroscopy is done in a sitting position with a standard posterior portal for visualization and an anterior lateral portal for instrumentation. The types of anterior capsule and subscapularis release are a longitudinal cut or an oblique cut, or a sieve capsule release, which are we using now. The results in the literature according to age groups, we group them to patients below 3 years, patient between 3 and 8 years, and patient between 8 and 16 years and above 16. Now, also in the literature, the gained external rotation after arthroscopic release will remain in the young children and older children. For example, this patient, 5 months after surgery, before surgery, he had no external rotation. A release was done, and the arm is placed in an external rotation spica. And after 5 months, he has more than 60 degrees external rotation and a good elevation. This patient had a failed open derotation surgery. We did for her an arthroscopic release, and this has improved her external rotation. The patient's age between 8 and 16 years, the gained rotation remains, and most of them needed transfer beside arthroscopic release of contracture. This 13 years old patient, 4 months after surgery, has a good elevation and a good external rotation. Okay. This 17 years old patient, he has a good elevation, but his problem is in external rotation. He has a head deformity, and this is bothering his daily living activity. So he wanted to improve this external rotation. Now, we did a surgery with zip release of the anterior capsule and put him in external rotation spica, and he gained about 45 degrees of external rotation. This case is a patient 20 years old with limited elevation and external rotation with a posterior subluxation. An arthroscopic release of the anterior capsule and subscapularis was done, beside reposition of the head anteriorly and open posterior capsular shift and latissimus dorsi transfer. This is the patient the day of surgery. Elevation is about 100 and no external rotation. It is minus. And after surgery, got this external rotation spica. 8 weeks before post-operative, the patient has a good external rotation. His elevation improved slightly, and he was very happy. Unfortunately, after 1 year, the patient lost of about half what he gained in external rotation, and maybe the reason he didn't do the exercises properly. Now, adult patients. For adult patients, we use a technique which we call 2+3 arthroscopic intervention with limited goals. These are patients who do not use the affected arm completely. They use only one arm. So we do this intervention to enable them to eat, to write, and shake hands, which is a very important function, especially if the affected side is the right side. Now, this 2+3 technique with limited goals is a bone intervention, a two-bone intervention, a subacromial decompression, and resection of the protrusion in the greater tuberosity, and 3 soft tissue interventions, the cruciate reconstruction of the supraspinatus, which I'm going to explain, and the oblique cut through the subscapularis, and also release of the inferior capsule. This is done to get the head, which is superiorly subluxated, in its position down. The instruments used is the giant needle to pass a transosseous suture through the head, and the so-called chop needle puller to pull the suture through the soft tissue. Now, it is based on making a T-shaped incision on the hyperredundant supraspinatus tendon and capsule, and then overlapping these two flaps on each other to shorten the width of the supraspinatus and tight it laterally. The technique is done by a T incision, and as I said, and then we pass a suture through the bone with a giant needle. And then with a chop needle, we go through the tendon to pull the suture inside the tendon, inside the posterior flap. And then we tie the posterior flap by pulling it anteriorly and fix it with another 2 or 3 sutures. Then put another suture posteriorly and also pulling it with the chop needle through the anterior flap and tie it over the posterior flap. So we have cruciate reefing, and at the same time increase the width of the supraspinatus. This is an intraoscopic view of this operation. Here is above on the left is the supraspinatus is ballooning above the biceps and the head. And below we see after reefing, the supraspinatus is tied immediately over the biceps tendon. Now, adults after surgery, they have to do physical therapy for 30 minutes at least a day, and this for 1 year, in order to keep the gained limited goals. This is a patient, 27 years old, and he had an active elevation of 40 to 80, an external rotation of minus 20. He had a relatively passive elevation of 80 and passive external rotation of 0 to 10. He never used the right arm. He always was dependent on his left arm. So his aim was to use his right arm in order to shake hands with other people and to write with the hand, and also to be able to eat. So these are the limited goals. This is the same patient 3 years after surgery with successful limited goals. He is still doing every day 10 minutes exercises for stretching of the external rotation and elevation at home, of course, and using a rubber band to strengthen elevation and external rotation. In conclusion, besides the advantage of arthroscopic interventions being less invasive technique, we have good results in arthroscopic release of anterior contraction. We also may consider tendon transfer associated with the arthroscopic capsular release. And we have a successful limited goals intervention in adults. It's very important, very essential to have a post-operative daily rehabilitation for at least 6 to 12 months after surgery, and maybe every day later for at least 10 minutes. Thank you very much for your attention.